Hanji Chodolok. So let's talk about the WBC disorders now. Now, in the main exam, they can give you 3 to 4 questions. In this, we'll be discussing about leukemia, lymphoma, and your plasma cell disorders. Now, WBC development, we have hematopoietic stem cell, which will first convert into myeloid stem cell. And in myeloid stem cell, when you give colony stimulating factor or colony forming units, it's going to convert into a promyelocyte, then a myelocyte, then a metamyelocyte, then a band form. This is the last cell of WBC maturation inside the bone marrow. It will give you WBC. The WBC, maximum WBC you have in your blood, that is your neutrophil. So neutrophil is the maximum, then lymphocyte, then monocyte, then your eosinophils, and then last is basophil. There are granulocytes, there are agranulocytes. Granulocytes are three, all the fill ones, and agranulocytes are lymphocytes and your macrophages. Now, the total leukocytic count we have is 4,000 to 11,000 cells per cubic millimeter. Because our hematopoietic stem cell bifurcates into two, myeloid and lymphoid. Myeloid will give you 6 cells of the blood. So in any kind of myeloproliferative disorders, all the WBCs except lymphocyte will rise. Whereas in a lymphoproliferative disorder, it is only the lymphocytes which is going to rise because it is lymphoid cell is only giving us lymphocytes. Okay. Now, these lymphocytes which we have, or leukocytes which we have, there are 5 types. As I said, 3 of them are granulocytes and 2 are agranulocytes. The largest WBC is monocyte. The smallest WBC is a lymphocyte. Neutrophils have 3 to 5 nuclear lobes. Eosinophils and basophils, they are bilobed. In eosinophil, you will have pink color granule, and in basophil, you'll have blue color granules, which are obscuring the nucleus. So you don't see the nucleus, but it is bilobed. Then hypersegmented neutrophil in megaloblastic anemia, more than 6 nuclear lobes. हाइपोसेगमेंटेड न्यूट्रोफिल पैल्गर anomaly जिसमें 2 ही न्यूक्लियर लोब्स मिलते हैं. Chediac Acid syndrome, Liz gene mutation, you see coarse granules in the neutrophils, and May-Hagelin anomaly, you see inclusion inside the neutrophil. Now, whenever we are talking about WBCs, the proliferation of WBC can be due to reactive proliferation, which is against the infections, or leukemoid reactions, or it can be neoplastic, where it can be leukemia and lymphoma. If we have increased WBC count, we call it as leukocytosis. Decreased WBC count, leukocytopenia. So, or leukopenia. So, for leukopenia, we have multiple reasons like chemotherapeutic drugs or radiation damaging the bone marrow, or due to some reason the bone marrow is disturbed, so you're not getting WBC production. For leukocytosis, different kinds of WBCs can be raised in different kinds of problems like neutrophils with bacterial infections, lymphocytes with viral infections, monocytes with chronic infections, eosinophils, chronic infections, specifically allergic and parasitic infections, and basophils in the patients of allergic infections, and we have to remember CML. Now, leukemia and lymphoma, what exactly is leukemia and what is lymphoma? Like I told you in the class when I was explaining this, that your hematopoietic stem cell bifurcates into myeloid and lymphoid. 6 cells, they are coming from myeloid, and only 1 cell is coming from lymphoid. Now, all these 6 cells which are coming from myeloid, they mature in the bone marrow and they directly come in the blood. Whereas a lymphoid, it first goes into the lymphatic vessels, they will sit in the lymph nodes, and once they are exposed to the antigen, they will proliferate clonally and then they will come in your blood. This is normal blood production. In a leukemia, the problem is occurring in the bone marrow because of the mutation either in the myeloid or in the lymphoid. These mutations can lead to proliferation of abnormal cells, the blast in the bone marrow. And when these blasts they come out in the blood, you call them as leukemia. And if it's a myeloid mutation, the bone marrow will be filled with myeloid blasts. And these myeloid blasts, they come out in the blood. You call them as myeloid leukemia. If it's a lymphoid mutation, lymphoid blasts will fill the bone marrow. They will come outside in the blood. You call them as lymphoid leukemia. Whenever one lineage is mutated, the other lineage is suppressed. So if there's a myeloid mutation, lymphatic is suppressed. If it's a lymphoid mutation, myeloid is suppressed. So how many types of leukemia we can have? 2 types, myeloid and lymphoid. Now, these myeloid and lymphoid leukemias, Chotu, they can be acute and chronic. Now, I would say it's an acute leukemia when the mutation is having a maturation arrest, where the proliferation of cells are seen, abnormal cells you are making, but there is no maturation which is occurring. So, in the blood, you will find more immature cells, and whenever there's a quantity of more than 20% immature cells in the blood or in the bone marrow, you call it as acute leukemia. In a chronic leukemia, proliferation of the cells are happening. All the cells you're making are immature or abnormal, but they are not properly immatured. I mean, you will see maturation. So in a chronic leukemia, you will see mature looking abnormal functioning cells, whereas in acute leukemia, you will find more immature cells because there's a maturation arrest. For a lymphoma, the problem is never in the blood or in the bone marrow. The problem is in the lymphoid organs. Now, which cells are reaching the lymphoid organs? Your lymphoid cells. So basically, your lymphoma will contain lymphoid issues. It is happening, it's a tumor in the lymphoid organs, and that is why lymphoma. And you will only have lymphoid blast in the lymphoma. Whereas in leukemia, you can have myeloid and lymphoid blast both. Now we have understood the difference between leukemia and lymphoma. In leukemia, it is blast either in the blood or in the bone marrow. Now, because we are talking about blood or bone marrow, we have to see the production. Now, I have told you your hematopoietic stem cell bifurcates into two, myeloid, lymphoid. Myeloid actually is giving you six cells. So all these cells are immature cells which are in the bone marrow. Slowly, they are maturing and they are becoming mature and they are coming in the blood. Likewise, lymphoid cells, all the three types of lymphocytes, the B, T, and NK, they are mature cells which are inside the bone marrow, and then eventually they're coming in the blood. So, if a patient is having these cells more in this area, that means these cells, the immature cells, they're coming more in the blood. You'll call it as acute leukemia because more blast in the blood, acute leukemia. Why would more blast in the blood will come? Because of maturation arrest. So if more lymphoid blast, ALL, more myeloid blast, AML. Likewise, chronic. In a chronic leukemia, you will see more mature looking abnormal functioning cells. So if these cells, they are seen more in more quantity in the blood, you call it as chronic leukemias. Here, this one, CML, this is CLL. Okay. Now differentiating between the myeloid and the lymphoid blast, but because myeloid leukemia is of more types, because it is six lineages it is giving you, six type of different cells it is giving you. So myeloid leukemia, they are bigger, so myeloblast is a bigger cell. Lymphoblast is a smaller cell. So everything is more in myeloid. Like myeloid is large, it has nucleus, it has nucleoli, it's having chromatin also is a little darker abundant cytoplasm. It might have vacuoles. And because it's a blast, so it will be CD34 positive. And it's a myeloid blast, so M for M, MPO positive. Whereas for a lymphoid blast, chota hai, nucleus hota hai, there is no nuclei in this. Cytoplasm is very scanty, no vacuoles, very homogeneous kind of a cytoplasm. It is a blast, so it is CD34 positive. But because it's a lymphoblast, so it will be PAS positive, which is periodic acid shift stain, most commonly used stain for a lymphoblast. But the more specific stain for a lymphoblast will be your TDT, terminal deoxynucleotide transferase. ये लिखा है यहाँ है, but it is for this. Okay. So you can see myeloid blast is a little bigger blast. ये बड़ा है. More cytoplasm, more nucleus. Whereas for a lymphoid blast, it is smaller. All cytoplasm, very scant cytoplasm. All nucleus, very scant cytoplasm. All nucleus, very scant cytoplasm. This is a lymphoblast. Okay. Now, talking about that, what is acute leukemia? Acute leukemia means there is arrest mutation. And in acute leukemia, more than 20% blast in the blood or the bone marrow. It can be a lymphoid blast, so ALL. It can be myeloid blast, so AML. Whichever leukemia it is, because you have mutation inside the bone marrow, one lineage is mutated, other is suppressed, and mutated lineage is making abnormal cells, and the suppressed lineage is not making any cell. So whether you talk about the normal RBC, normal WBC, normal platelet, nothing will be seen. So patient is going into pancytopenia, whereas blasts more than 20%. If there is more than 20% myeloblast, AML, more than 20% lymphoblast, ALL. Now, in the AML ALL, if there is any central infiltration, it is more ALL. So, brain, mediastinum, testes, it is all ALL. If it's gum, so AML. And if they are saying OR rods, it's the hallmark feature of ALL. Beta OR rod कहीं marked है ना, तो इसका मतलब 100% it is AML. It can be anything else. OR rods के दो नाम है, एक तो OR rod है. If there is a single rod, if you see a single rod, ये देखो ऐसे single rod, it is called as OR rod. But the moment you see these crisscross rods, it is OR rod only, but it is called as faggot cell. क्या बोलते हैं इसको अपन? We call it as faggot cell. Okay. Then, if specifically we talk about ALL, बहुत ही simple है. More than 20% blast seen in the blood or the bone marrow. Which blast? Lymphoid blast. Now, if we are talking about ALL, there can be three kinds of ALL: B type, T type, NK type. अपन ने पहले से किया हुआ है that B type problem are the more commoner problem. So which type of ALL is more common? B type of ALL is more common. Simple. B type बच्चों में दिखेगा. B for बच्चे. B for baby. So B type of ALL is more common. ये आपने याद करना नहीं है. Risk factors. Fab classification, WHO classification, Fab के accordingly more than 30% lymphoblast in the blood or in the bone marrow. It is three types L1, L2, L3. L3 याद रखना है बस. L3 में it's a different kind of a blast which has vacuoles. Normally lymphoblasts do not have vacuoles. Who has vacuoles? Myeloblast. But L3 is a different kind of a lymphoblast where there's an exception and you see vacuoles. This vacuole is filled with lipid. Normally for a lymphoblast, what is the stain we discussed just now? PAS and TDT. But this L3 will be negative for that. And what it is positive for? The stain for lipid. What is the stain for lipid? Sudan. So SBP positive. Okay, this is your FAB classification. We're not following this classification now, but still I've told you. WHO classification is what something which we are, we are following. And in this WHO classification, we can have a pre-B type of ALL, pre-T type of ALL, and how many types of lymphoblast we will see. More than 20% lymphoblast we will see. And this more than 20% lymphoblast, this classification is based on cytogenetics. So problem कहाँ है ये देखना है. So B type, T type और NK type problem हो सकती है. NK is very rare, so we will not discuss. B and T will discuss. B always more common, always seen in child, and the prognosis is always good. T less common, seen in adults, and prognosis is poor. Choto. For a B type ALL to develop, the mutations which we see are EBF mutation or PAX5 mutation. Remember the EBF and PAX5 for B. Okay. And for T, any kind of T cell problem, you will have notch gene mutation. So T for T, yaad rakhna. Forget about this now. Good prognosis and bad prognosis ALL. Good prognosis ALL not generally means B type. No. Good prognosis ALL could be B and T both. So what are the things which makes an ALL good prognosis? That's what we are going to discuss. पहली ट्रांसलोकेशन है बेटा 1221 mirror image and trisomy 4710. Hyperploidy ज्यादा is good plus female gender and age group 1 to 9. बैड प्रोग्नोसिस एएलएल में दो ही ट्रांसलोकेशन अपने ने क्या फिलाडेल्फिया क्रोमोसोम 922 तुमको याद आ रहा होगा प्लस 814. 814 इज द मेजर ट्रांसलोकेशन फॉर बर्किट एंड बर्किट बेटा 814 जब भी आएगा ना इट इज ऑलवेज बैड. सो 922 814 कैसे याद किया था 922 फिलाडेल्फिया क्रोमोसोम दिस इज मेजर साइटोजेनेटिक एबनॉर्मेलिटी फॉर सीएमएल. अब दिस इज फॉर सीएमएल नाउ इट इज कॉजिंग एएलएल. तो प्रॉपर्टी तो ये सीएमएल की है नाउ इट इज कॉजिंग एएलएल. तो यार फिर बैड प्रोग्नोसिस ही हो जाएगा ना. इट विल बी अ बैड प्रोग्नोसिस. सो यू विल हैव ट्रांसलोकेशन 922 814 plus hypoploidy age group less than 1 more than 9 plus more common in males as compared to females. This is ALL. AML की बात करते हैं again more than 20% myeloblast in the blood of the bone marrow. Classification में it will be FAB and WHO. And FAB classification more than 30% blast. ALL के कितने types थे? तीन types थे. ठीक है उसमें L3 याद करने के लिए बोला मैंने that L3 you learn because it contains vacuole so it is SBB positive. But in AML there will be 8 types from M0 to M1. M0 कैसे बताया without differentiation, M1 with differentiation, M2 with maturation. So without differentiation, without maturation. Oh, sorry, with maturation. Then M3. M3 कैसे याद किया था अपन ने? Pro. M4 myelo mono. M5 mono. M6 RBC. M7 platelet. So without differentiation, with maturation, pro, myelo mono, mono, RBC, platelets. ठीक है इसको दो बार बोलना याद आ जाएगा. Worst prognosis M0 जिसका कुछ नहीं पता. Most common M2 which is associated with chloroma. Chloroma क्या होता है? When the leukemic cells they infiltrate in the surrounding tissue. This is chloroma. M3 the three-letter disease DIC and or rod. The hallmark feature of AML is seen more commonly with M3. 4, 5 gum hyperplasia and 7. 7 is the Down, so it is associated with Down syndrome. AML, this is FAB classification, but AML with WHO, it is more than 20% myeloblast in the blood of the bone marrow. तीन ट्रांसलोकेशन याद करने के लिए बोला था बेटा. And AML is a bigger leukemia, right? So 8 से ही होगा, but 821, bigger number of chromosome. वहां पे क्या था ALL में 814, यहाँ पे क्या है 821. Then 1517 and 1616. All three are good. ये bad याद नहीं करना है. AML is the most common leukemia which is seen after radiation or chemotherapy. With M3, you see DIC. And for that, I told you this. You don't have to learn. They won't ask you. They can just ask you. They can give you the DIC is happening in a patient, which kind of translocation is seen. So DIC, if they say translocation 1517, because translocation 1517 is associated with M3. And what is M3? Pro. Most common leukemia after radiation and chemotherapy is AML. ठीक है बाकी और ये कुछ याद करने की जरूरत नहीं. Blood investigation सबसे पहले करोगे बेटा. Any leukemia patient first investigation will be blood. So in the blood you will see all the normal working cells low. So RBC, WBC, platelet all will be low. Patient is having pancytopenia. Pancytopenia होगा तो hepatosplenomegaly and lymphadenopathy हो सकती है. So every leukemia patient will give you this. Yes, megaly will be more commonly seen with myeloid leukemias M4M, and lymphadenopathy will be more commonly seen in lymphoid leukemias L4L. ठीक है. But let's say in the blood you are not seeing 20% blast. What you do? Can you call it as chronic? No. You do a bone marrow aspiration biopsy. Even the bone marrow aspiration and biopsy also you are seeing less than 20% blast. Then only it becomes chronic. But in the bone marrow, if it becomes more than 20% blast, it is acute. So these kind of leukemias where in the blood you are not seeing 20% blast, but in the bone marrow you are seeing more than 20% blast, you call it as aleukemic leukemia. Once you're done with the bone marrow thing, you can also use stains or you can use CD markers. So ये भी अपन ने याद किया 34 blast के लिए 45 normal functioning WBC के लिए. NK cell बेटा अभी करके आया immunity में 1656. B cell all double digit markers 19, 20, 21, 20 ऐसे. T cell single digit markers 1 to 8 any marker can be there but better is 3. For platelets, Danda P. So this is 4161. And for monocytes 4 digit. 4 are na MONO4 so 1464. Stain आपको पता ही है. For a lymphoblast, it is PAS for TDT, or for myeloblast, M for M, it is MPO. And if you learn this, so it becomes very easy for you to find out. Else, what you can do fish. Fish से आप सारी translocation पता लगा सकते हो. Good prognosis ALL translocation was 1221. Poor prognosis ALL translocation was 814 and 922. AML के साथ we did 3 translocation 821, 1517, 1616. All this can be seen. Treatment आपको याद नहीं करना है. Forget about it. पढ़ो भी मत. याद ही नहीं करना है. ठीक है. देन ALL एंड AML के बीच में जो डिफरेंशिएशन है मार्कर डिफरेंशिएशन ये भी आपको बता दिया. बी सेल डबल डिजिट 19 20 21 22 23 like that. Best is 19. T cell it is CD 1 to 8 anything but 3 is best. And these B cell and T cell beta they are positive for CD10. It's a common ALL marker and this kala is not positive for NK cell and that is why it is called as null cell. कई बार बता दिया मैंने आपको. I hope you'll remember. For AML these are the markers. Just remember them. 3 3 वाला. 13, 33, 117, and it is NPO positive. To differentiate between ALL and AML, the age group is very important. If they're giving child, generally they're talking about ALL. If they're giving middle age and elder people, it is AML. So in ALL, all will be like central involvement, and in AML it will be peripheral involvement. In peripheral smear, there will be more than 20% lymphoblast in ALL, more than 20% myeloblast is in AML. Stain में pass positive, TDT positive, ALL, MPO positive, it will be AML. Markers आपको भी मैंने बताया ही है. Translocations you already know. For ALL it is 1221, 814, 922. For AML it is 1517, 1616 and 821. And Kala is only a marker of ALL. It will never be seen present in AML. So these are your acute leukemias. Okay? For chronic leukemia, 10 to 19% blast in the blood of the bone marrow. For CLL, it will be 10 to 19% lymphoblast. And for CLL in the class, we have learned 6 points. What was the first point? The first point was that most common type of CLL B type. B cell क्या करते हैं छोटू? Antibody बनाते हैं. These antibodies will malfunction. They will kill our body's normal cells. So the second point we learned was that CLL will be causing pancytopenia with hepatosplenomegaly and lymphadenopathy, which is called as Evans syndrome. Third point, most common translocation for your CLL is 13q deletion. Notch and zap will give you poor prognosis. ये हो गया. Never arise after radiation exposure. फिर ये हो गया. And last thing is that you see which cells? The smudge cells. It is also called as convent girl appearance because this is CLL, no? So in CLL, there will be no arrest. So what kind of cells you will see? Lymphoid cells. They will be looking mature, so lymphocytes, and they will be functionally abnormal. So they are not going to fight against the infection. And whenever one lineage is mutated, the other lineage, it is suppressed. So myeloid lineage say you will not find anything. If you're not finding myeloid lineage say anything, you will have deprived RBC, deprived neutrophils, monocyte, eosinophil, basophil, platelet. So every cell will be less. Only and only lymphoid cells will be high. No maturation arrest, no. So only and only lymphocytes will be high. So this is what you're going to see. You find ALC increased, more TLC. Okay, and this is the smudge cell. And Richter syndrome, your CLL converts into DLBCL, diffuse large B cell lymphoma. It's a non-Hodgkin's lymphoma. So these are the things you have to know about the CLL and the question will be done. Treatment आपको पढ़ना ही नहीं है. Then your chronic myeloid leukemia. Chronic myeloid leukemia 10 to 19% myeloblast because it's myeloid. It is more commonly seen in males. Beta age and male. ये बहुत इंपॉर्टेंट है 50 to 60 years में मोर कॉमन ल्यूकीमिया हैपनिंग इज सीएमएल इट्स अ गुड प्रोग्नोसिस ल्यूकीमिया द pathogenesis is Philadelphia chromosome where we have translocation 922. Okay. So on chromosome number 9, you have your ABL gene, and 22, you have your BCR gene. So you will have ABL BCR translocation, which will activate your tyrosine kinase receptor, where the cell division will increase, apoptosis will decrease. So whatever cells you're making, they're not being killed and they're being, accumulated inside the body. And all these cells, there's no maturation arrest. So what kind of cells you will see? Mature looking abnormal functioning. Which lineage you are mutating? Myeloid lineage. So all the six cells will increase. Only one cell will be decreased, and that is your lymphocyte. Because when one lineage is mutated, the other lineage is suppressed. Chronic leukemia, it can have multiple phases, like chronic, accelerated, and blast crisis. In a chronic phase, the blast count is even less than 10%, and basophil are 10 to 19%. In an accelerated phase, 70% of patients are coming to us in accelerated phase, 10 to 19% blast, and more than 20% basophils. And the blast crisis, the blast count becomes more than 20%. And CML can transform into acute leukemia. And this acute leukemia, it can be AML and ALL. AML is 70% seen with CML patients, and 30% it can be ALL. Okay? Now, you can have fever, you can have malaise, you can have weight loss in these patients. Every leukemia patient can have it. It's a myeloid leukemia, so you will have Migeli more, hepatomegaly, splenomegaly. And because you're making all the WBCs more, basophils will be more. Basophils are same as mast cell in the tissue. So you have more histamine, so patient ko itching ka problem. Every WBC will look more, except for lymphocytes. Even the RBC and platelet will be a little more. But all of them, they are looking more. They are looking normal, but they are functionally abnormal. So patient will have pancytopenia. Patient will have anemia features, bleeding, infection, everything will be seen. But blast will be 10 to 19%, and what kind of blast they will be? It's a myeloid leukemia, so myeloblast. And eosinophilia, eosinophil बहुत ज्यादा दिखेगी, basophil बहुत ज्यादा दिखेगी. You can have neutrophilia, you can have lots of monocytes, but all these cells are looking normal, but they're not functionally abnormal. This kind of appearance is called as chotu, garden party appearance, and college girl appearance. How do I find out that these are only looking normal, they're functionally abnormal? By doing the lab score. Every normal WBC, which is functionally normal, is having lab enzyme. So in normal person, you and me, we have lab score 40 to 100. But in CML, the count is very high, the WBC count. But actually, all these WBCs are functionally abnormal, so lab score will be less. There's a reaction called as leukemoid reaction, which looks like leukemia, but it is not cancer. It's a normal reaction where the WBCs are fighting the pathogen. So they are too much because the pathogen is very heavy, but it looks like कि leukemia हो गया patient को. So many WBCs have come, but we check the lab score is very high, so we understand that these WBCs, they are not abnormal looking, abnormal functioning, normal looking WBCs. These are normal looking, normal functioning WBCs. Then why they are so much? Because it's a leukemoid reaction, looking like leukemia, not leukemia. So lab score is low in CML, increases in leukemoid reaction, rest everything you know. You have a pseudogaucher cell. It's a crumpled tissue paper chromatin cell which is seen in CML, the blast, and the treatment is tyrosine kinase inhibitor. This is the only treatment you should know. Tyrosine kinase inhibitor, which is imatinib, because CML is happening due to what? Due to overactivation of tyrosine kinase receptor. So you inhibit this receptor and the things are fine. But the treatment of choice is bone marrow transplant. As simple as that. Then your polycythemia vera, only thing. JAK2 mutation, predominant rise in the RBCs. And criteria you already know, EPO less, minor criteria. Major criteria में क्या होगा? JAK2 mutation positive and more hemoglobin. ठीक है? What is the treatment? Phlebotomy. Then I told you this also that polycythemia means increase in number of cells. Polycythemia vera matlab everything is increasing, but predominantly RBC. Polycythemia rubra vera. It is rubra na redness, so only RBC increases. Then primary myelofibrosis, again JAK2 mutation, but it activates the production of PDGF and TGF beta, and therefore patient is having too much of collagen in the bone marrow. Nothing is seen inside the bone marrow except for collagen. So patient is into pancytopenia. In the bone marrow aspiration biopsy, छोटू you will find dry tap. कुछ नहीं निकलेगा, नल सूख गया, कितनी भी कोशिश कर लो. ठीक है, dry tap, decrease in cellularity, collagen will increase, and the RBCs which will come out, teardrop RBC, two-time exam question. Teardrop RBC, dacrocytes, they are seen with primary myelofibrosis. Pencil cells, बेटा गलती नहीं करना, this is seen with IDA, iron deficiency anyway. And essential thrombocythemia, इसमें platelet बढ़ जाएगी छोटू. But all these platelets will be abnormal and the patient will have bleeding episodes. What is the reason for this? JAK2. So polycythemia vera, primary myelofibrosis, and your essential thrombocythemia, same mutations, JAK2. For CML, it was Philadelphia chromosome translocation 922. There is one more thing, like in leukemia. So leukemia के नाम से ना एक और है hairy cell leukemia. When we talk about the hairy cell leukemia, the mnemonic you have to learn is ABCT, annexin A1 positive, B से BRAF gene, B cell tumor, more in boys, CD103 positive and TRAP positive. And it gives you fried egg appearance क्योंकि ये जो cells हैं, they have these hairy projections. ये hairy projections हैं इनकी. Therefore, they are called as hairy cell leukemia, but they give you a fried egg appearance. So this is all about the leukemia. Now let's talk about lymphoma a bit. Lymphoma में बेटा first lymphoma we are talking about is Hodgkin's, and second we'll talk about non-Hodgkin's. Because I said that lymphoma is only an involvement of the lymphoid organs, and lymphoid organs में what are the cells? B, T, and NK. So either there's a mutation in that leading to problem with the B cell or T cell or an NK cell. More commoner will be B cell. So I'm talking about the B cell problems. Hodgkin's and non-Hodgkin's B type problem. Hodgkin's are less common, non-Hodgkin's are way more common. Hodgkin's only involve the lymph nodes and more commonly cervical lymph node, whereas non-Hodgkin's anywhere in the lymphoid organs. ठीक? Hodgkin's are good prognosis. Why? Because they are having a contiguous spread, one after another. Non-Hodgkin's vague spread, so bad prognosis. Hodgkin's lymphoma, B cell involvement, EBV virus. आपने दिया ना CR2, CD21, EBV enters through it, and which B cells, post-germinal B cells are involved. ये आपने याद रखना है. Hodgkin's lymphoma 5 types. अब दोबारा समझाना नहीं है बेटा, आपको याद होगा. Classical, non-classical. Non-classical only one type, classical 4 type. ये non-classical में क्या है छोटू? Predominant. और classical के 4 type, स्क्लेरोसिस मिक्स्ड रिच पुअर. याद किया था ना अपन ने? प्रीडोमिनेंट, स्क्लेरोसिस मिक्स्ड रिच पुअर. Hodgkin's lymphoma में characteristic finding which should be always seen is RS cell, giant cell, pink color, two nucleus, two nucleoli. ठीक है. अब RS cell भी 5 तरीके के हैं. Two PRS cells, the popcorn one and the pleomorphic one, which has multiple nucleus shapes and sizes. One is mononuclear, जिसमें single nucleus है. एक जो आपने ये आर एस सेल देखा बेटा, ओवल आई अपेरेंस सेल है ना, ये क्लासिकल आर एस सेल है. और एक आर एस सेल होता है छोटू, लैक्यूनर आर एस सेल, वेयर यू हैव स्पेस बिटवीन द साइटोप्लाज्म एंड द न्यूक्लियस विच इज लुकिंग व्हाइट. एनी स्पेस इन द पैथोलॉजी स्लाइड व्हाइट कलर. नाउ यू डायरेक्टली हैव टू लर्न. ये जो है डिफरेंशिएशन आपको पता ही है, माइक्रो ऑल्सो यू हैव डन इट. आर एस सेल विल बी पिंक इन कलर. It will have proper to nucleus, proper to nucleoli, and very clean structure. जैसे वो दिख रहा है. But this here you are seeing these blue dots, dark blue color. So if you have a basophilic structure, dark bluish color, in looking like owli, but you are seeing these blue color dots here, blue color inclusion here. This is owli inclusion body seen with CMV virus. RS cell, it's an inflammatory, finding in the Hodgkin's lymphoma, it will always found with the inflammatory cells. Why? Because RS cell can secrete multiple interleukins, like 6, 8, 5 eotaxin. So they will call other cells. 6 is for all the inflammatory cells. 5 is for eosinophil. Eotaxin is for eosinophil. And 8 is for neutral. So whenever RS cell is secreted, all the inflammatory cells are around it because it is secreting multiple interleukins. But if the question is, what is the interleukin responsible for RS cell secretion, then it is interleukin 13. Now you have classical and non-classical types. तो आपने जो जो मोटे मोटे पॉइंट्स याद करने में बता देता हूँ बेटा. मेजॉरिटी आर क्लासिकल, very few are non-classical. Number one. Number two, this nodular lymphocytic predominant, it's a best prognosis one, and poor one is the worst prognosis. Mixed cellularity, most commonly seen in India, and nodular sclerosis, most commonly seen worldwide. RS cell बेटा दो P हैं, predominant and poor, उनके साथ PP आएगा. फर्स्ट predominant popcorn, लास्ट poor pleomorphic. M के साथ M, mixed cellularity, mononuclear. रिच के साथ यू विल हैव क्लासिकल एंड लैक्यूनर. स्क्लेरोसिस मतलब हार्डनिंग, और हार्ड चीज कैन क्रिएट अ गैप. सो लैक्यूनर आर एस सेल. द ओनली थिंग इज दैट दीज टू, क्लासिकल एंड मोनोन्यूक्लियर, you cannot decide just by presence of these two that which type of Hodgkin's lymphoma it is, because they can be seen in both. And for all these four classical types of Hodgkin's lymphoma, the marker is CD15 and 30. With a Hodgkin's lymphoma, you see pale Epstein fever. Hodgkin's lymphoma done. The investigation of choice will always be biopsy, because on biopsy you can find RS cell, and RS cell is the hallmark feature of Hodgkin's lymphoma. Then you have Ann Arbor staging. In Ann Arbor staging, you have 4 stages. In stage 1, single lymph node involvement, no extra or single extra lymphatic or organ involvement, which is very rare. Okay. In type 2, two or less than two lymph node, but on the same side. In type 3, both sides of the diaphragm, and stage 4, anywhere. These are N arbor staging you should learn. That's it for Hodgkin's. For a non-Hodgkin's lymphoma, beta, we are only talking about the non-Hodgkin's lymphoma coming from a follicle, B cell follicle. Follicle has got three portions: the marginal, the mental, and the germinal center. From a marginal zone B cells, if a lymphoma occurs, we call it as marginal zone lymphoma translocation 1118, is also called as maltoma. From a mental zone, if the B cells are mutated from there and you're having a lymphoma, mental zone lymphoma, translocation 1114, छोटा number है इसमें 1114. And with this mental zone lymphoma, just learn साइकिल चलाते चलाते socks पहन के mental हो गए. ठीक, socks 11 positive, cyclin D1 positive. Then you have germinal center. From a germinal center, you have three lymphomas coming. First is follicular lymphoma, second is DLBCL, third is Burkitt's. Follicular lymphoma, 14 from the mental zone, 18 from the marginal zone. So it 14, 18 translocation. Follicular lymphoma, best prognosis lymphoma because it is very slow growing. And BCL2, follicular lymphoma, FL, two words, this is BCL2. And DLBCL, it is seen with HIV. भाई याद रखना HIV के साथ most commonly seen in India. And BCL molecules are BCL6. Burkitt's c-MYC mutation, worst. B. Every translocation starts with 8. B is an even letter, so 8-2, 8-22, 8-14. Most common is 8-14. And the appearance is starry sky. This is your Burkitt's. Okay. Now, आपको पता है stars are macrophage in sky जो है blue color, that is your tumor cells. Nothing, कुछ याद ही नहीं करना है इसमें. Hairy cell leukemia मैंने बता दिया. Last part, that is plasma cell disorder, which is multiple myeloma. Beta, plasma cells, they are the cells which are going to give you antibodies. They are generated after B cell is activated. Now, let's say there is translocation 1114, okay, or there is any 13q deletion where your B cells are mutated, and because of this B cell mutation, you are having abnormal plasma cell production. This abnormal plasma cells, they are going to make abnormal antibodies. Abnormal antibodies in which cell? देखो बेटा, normal antibodies, they have high heavy chain and light chain. In a plasma cell disorder, when the plasma cells are mutated because of 1114 translocation or 13q deletion, the antibodies only start making light chains. So these antibodies, they are there, but they are not functioning properly because they do not have the heavy chain. Now, when these antibodies are more, they are proteins, right? These proteins can go to the kidney, can damage the kidney, can be seen in the urine as Benzone proteinuria. When the kidney is damaged, patient is not going to secrete EPO, patient will have anemia, or there will be, seen AL type of amyloid. All this will be seen. You are making too much of antibodies. Which antibodies are more commonly made because of this monoclonal protein? Abnormal IgG antibodies. And this abnormal IgG antibody, beta, it can start the osteoclastic activity. So patient will have a lot of osteolytic lesions. So whenever we are diagnosing the patients of multiple myeloma, in the plasma cells in the bone marrow will be more than 10%. You will have a lot of M protein positivity, and one feature out of CRAB should be there. Now, what is CRAB? Hypercalcemia, renal failure, anemia, or bony lytic lesions. Any one should be present. There's one more criteria for multiple myeloma, that is slim CRAB. तो ये सेम ही चीज है जो मैंने अभी आपको ऊपर बोली. ठीक है. Now, for any multiple myeloma, you will find antibodies damaging the RBCs, and RBCs, they start accumulating over each other. We call it as chain of, yeah, stack of coins, and it is also called as Rayleigh formation. You see a lot of abnormal plasma cells. Now, these M protein which you are making, the abnormal protein, the light chain protein, normally our, like I told you that our uh, electrophoresis for us in a normal person will be like this: maximum albumin, that alpha 1, alpha 2, beta, and gamma, minima or gamma. But in multiple myeloma, the M protein which you are making, it is going to deposit on the gamma chain. And when it is depositing on the gamma chain, you will have like this spike on the gamma chain, the gamma band. So you'll have a spike. This spike is called as M spike. It is on the gamma region. Which chains you are making, kappa and lambda, better is kappa. And which antibody? IgG antibody more commonly, but I am not saying that multiple myeloma cannot have IgM or IgA. It can have any, but more commonly IgG. And the urine, you'll have benzose proteinuria. And the one more thing which you have to learn is that these patients can have deposition of M protein in the plasma cell itself because the plasma cells are making so much of protein. So plasma cell उसके अंदर ही protein deposit हो जाता है. If the plasma cell protein is getting deposited in the nucleus of the plasma cell, nucleus is the daddy organ, D for Dutcher. In the cytoplasm, Russell. If it is covering the entire cytoplasm with vacuoles, Mott cell, and it is looking like a flame, so it's a flame cell. So देखो, this is your flame cell. Then it is inside the nucleus. So this is your Dutcher. This here, entire nucleus, entire cytoplasm with the vacuoles, so Mott cell. And this little bit vacuoles in the cytoplasm, Russell. So four types of these cells. And now ये वर्ड प्लाज्मा सेल ल्यूकीमिया. Plasma cell leukemia तब बोलते हैं when in the bone marrow you have less than 10% plasma cells, but in the blood you are having more than 10% plasma cells. So you are seeing more than 10% plasma cells in the blood, but you're not seeing them in the bone marrow as such. So you call it as plasma cell leukemia. MGUS, it is how do you differentiate with multiple myeloma? MGUS you differentiate with the help of less than 10% plasma cells in the bone marrow. This is M protein to positive hai, but then this is having CRAB negativity, and the antibody also is not much. IgG antibody is not, it is less. Smoldering myeloma is same as multiple myeloma, except for smoldering myeloma is CRAB negative. So more than 10% plasma cell, M protein is also positive, but CRAB negative hai bhai ye. And Waldenstrom macroglobulinemia, yaad hi nahi karna, it is hyper IgM syndrome. Just forget about it. So this is your multiple myeloma. We have discussed all about ALL, AML, CML, CLL. I've told you about the polycythemia, the essential thrombocythemia, and primary myelofibrosis, all about lymphomas and multiple myeloma. Now, why I did it this way so that you can just listen to me. And in the class also, I said the same thing, so you'll remember what I said in the classes. And I hope this revision video will help for covering the WBC disorders. So just quickly go through topic by topic and you'll be okay. Bye bye. See you in the next.